Thank you for joining us for this AdventHealth virtual seminar. We hope you'll find the material presented helpful and informative.
Good morning. My name's Steve Raterman. I'm an orthopedic surgeon with AdventHealth in Wesley Chapel, Florida. And this morning I'm going to spend a few minutes talking with you all about the latest advancements in hip and knee replacements. So you would consider a hip and knee replacement to be necessary for a fairly severe arthritic condition, and many of you all may not understand what arthritis is. So as we all age, we start to have wear and tear in our joints. This can be a combination of trauma, of your size. It can be a genetic overlay to this. And as a result, the smooth gliding surface that covers your joints, it begins to thin and wear out. As that occurs, you start to have raw areas of bone. Once those raw areas of bone begin to coalesce and get larger, you start to have frayed nerve endings, which become painful. At that time, you start to have a joint, for example, like a hip, where you have the smooth gliding surface is worn on both the socket and also the femoral head. And as those two pieces begin to articulate together, it begins to ache and hurt. That causes a great deal of pain, which can be so severe that it forces you to limp or to miss work, or maybe even more importantly, to miss fun things such as activities like golf or tennis or other activities that you would want to do for fun. So when you have this kind of an issue, you begin to come to a surgeon such as myself. And when you first come in, we'll take some special orthopedic x-rays and we'll assess how bad your arthritis is. At that point, we may recommend some simple medications such as Advil, Tylenol, Aleve, and perhaps even some activity modifications such as dropping your impact load from running to cycling. We may suggest weight loss. As a result of the stiffness and a result of the swelling that's present within your joints, we may send you to physical therapy. And the therapist will work with you on strengthening the muscles around your swollen, achy joint, and also work on stretches for you to do to maintain your suppleness as you are proceeding with the disease. If that doesn't work, then we move on to stronger medications and even considerations for injections such as cortisone shots or other types of shots such as stem cells. At that point, if all else fails, the dreaded surgery card now comes out of the deck. And at this point, you're looking at an operation. The operation is done mainly for pain relief, but also to improve function. At AdventHealth Wesley Chapel, the first topic is resurfacing. And so if you are a young male under the age of about 62, you might be a candidate for an operation called a hip resurfacing. And unlike a traditional hip replacement, where the entire ball is removed and an artificial ball and stem is placed into the bone, we preserve that bone and we resurface your socket and we resurface the ball that you have. So the shell goes into the acetabulum of the socket in the usual manner. And then instead of taking a saw and removing all that bone, we save that bone for later use and we fashion a metal cap on top of that. It feels more normal than a regular hip. It also preserves the bone for later use. This is important if you're young, and you might need a second operation in 20 or more years later. You can convert this operation very easily to a hip replacement at a later time. It fits together very nicely like this. It rolls very smoothly, and in addition, it's about the same size ball as what you started with. That makes the hip very, very stable. So it's very difficult to dislocate a hip resurfacing because of the size of the ball. If you're a young, active person and you have been told that you perhaps need a hip replacement, but you may need to quit your high-demand job, such as a first responder or a firefighter, or anybody who has to do significant stooping, squatting, or bending as part of their daily job, this is a very good operation for you. We do a number of very high-demand athletes. We also perform this operation on patients that are younger that might need a second operation in the future. We are a tertiary referral center for resurfacing from all over the Southeast, and we have performed over 3,000 of these procedures, and it is a very successful operation given the best indications. Usually, as I mentioned, you need to be younger, you need to have excellent quality bone, and you have to have a high demand job, a high demand, and seek to go back to high demand activities. If you don't necessarily meet that criteria, we still have an option for you. And the next option I would talk about on the hip side is called a dual mobility hip. So it is similar to a regular hip in that you have a short stem, such as this, and then the ball attaches to a plastic ball, which rotates inside another shell like this. So it is a ball within a ball that rotates within a metal shell, similar to a resurfacing. The net effect is that this ball conglomerate is about the same size as the ball that you had to start with, and likewise is very stable. It also has a very good range of motion, as you see here, and it can go through extreme ranges of motion to allow for less impingement as you go through your everyday activities. Candidates for this might be somebody who wishes to do active yoga or has a high demand or range of motion or has a history of looseness or laxity in their joints. The last option that we have is what's called a computer-navigated total hip replacement. And our mnemonic for this is the OPS, Optimal Positioning System for a Hip Replacement. And in this operation, we use a special set of x-rays of you stepping up, standing, and sitting, and we see how your lumbar spine and your hip socket react in real life. By doing this, it improves our positioning component of where to put the hip to fit your body as perfectly as possible. The net effect of this is that it reduces the risk of dislocation. It also allows us to do this through a very small incision and in a minimally invasive manner without cutting any muscles from an anterior approach. It is an extremely versatile tool that we use, and as a result, we also obtain a CT scan. The CT scan looks for any impinging bone spurs that might affect the function of the joint. It also allows us to check for your leg lengths, another very common problem with standard hip replacements. By doing this, we are aware of exactly how long your operative leg is in comparison to your non-operative leg is, and it fashions a guide for us in surgery that we use to match up to the model that is created for us so that we can give you the best appearing and best functioning hip we possibly can. Assuming that you are a 70-year-old person and your hip has got very bad arthritis and it's worn out and you failed conservative care, then you're a candidate for a standard hip replacement. To refresh your memory, as you know, the ball has begun to show a lot of wear, the socket has shown a lot of wear, and so for a standard hip replacement, one of the first steps in the operation is to redo the lining. So that is simply debrided out and removed with special instrumentation. And at that point, a new socket is placed inside of your pelvis. And that socket is press fitted and bone grows into it. And a plastic liner is then placed thusly. Likewise on the femoral side, the femoral bone is removed and the top part of the femur is taken away. And at that time, a new stem is placed inside the bone. And usually in this day and age, a ceramic ball is placed, and that ceramic ball offers very low wear and very low friction, and it matches up to the plastic liner that's already been inserted. So it's a ceramic ball with a plastic liner that's inserted with a minimally invasive, non-muscle tearing technique with a small incision, and that is a modern total hip replacement. On the knee side, again, knee arthritis is an extremely common affliction in the United States. It accounts for millions of dollars of lost patient days in work and play, and so traditional knee replacements involve an operation where in the patient world, many of the patients feel like we take a chainsaw and we make a cut above and below, and we grab the medium off the shelf and we chunk in a medium. In real life, we actually keep all of your ligaments and soft tissue together except for one. We very carefully bend your knee forward, and we place a metal cap on top of the knee that you currently have. And this cap takes off maybe 8 or 9 millimeters. Likewise, as we bend the knee forward, we bring your tibia forward, your shin bone, if you will, and we put a metal tray, and then we fashion a varying thickness piece of plastic into that arrangement, snap it back together. All your ligaments are still functioning, and the knee is still yours, and then we put a small plastic button underneath your patella. So that's the core effort to a modern knee replacement. The problem with a knee replacement is that the patient satisfaction on pain has always been very, very good. However, the patient satisfaction on a standard knee replacement for function has had a bit of a problem. About 20% of patients have complained over the years that their knee isn't very stable going up and down stairs, or if they want to play a high demand activity such as tennis where you're stopping, starting, pivoting, twisting, that the knee just doesn't perform as well as the natural knee does. So we've been on sort of a mission to try and improve the function after knee replacement for the last 20 or 30 years. We think we've made some significant strides forward, and we now feature a robotically assisted knee. This is a second generation knee, and the robot is not a cumbersome piece of gear within the room, but rather it fits inside the incision, and it takes the pressure points and checks your range of motion and your ligament balance that I've mentioned to previously in real time in surgery, and we analyze that on a screen. From that analysis in real time, we are allowed to choose the most appropriate sizes and thicknesses, and it also allows us to rebalance your ligaments in real time so that at the end of the operation, we put your knee through a range of motion once again, and we make sure that your knee has no loose spots, not in any point in the range of motion being too tight or too loose, so that you can perform to the highest level of function that you wish. By doing that, we feel that our patient satisfaction scores are rising and our functionality is improving. The pain relief has always been good, and joint replacement is an extremely successful operation.